Good afternoon, folks who are on the call so far, and I know there's a few more joining us here in the next few minutes. But given that we have a tight time frame today and quite a bit of substance to get through with you, we're going to go ahead and start very promptly here, right at 2 o'clock, if you don't mind. For everyone's benefit and those who aren't on yet, we will be recording this webinar, and it'll be available on the Medicaid Transformation website shortly at the conclusion. In the way of introduction, my name is Nathan Johnson. I have the privilege of serving the Healthcare Authority as Chief Policy Officer, and I'll be walking us through this presentation today. We're going to ask that you use the online questions pane to submit questions throughout the webinar. We'll be tallying those, of course, theming them, and getting to as many of them as possible by the end of the presentation. By now, if you can't hear me, you're probably letting us know through that questions pane, but there is some helpful information there on the slide in case you're having any audio difficulties. So here is our ambitious agenda for this afternoon, and again, we're going to try to be very timely in the conclusion of this, largely because we are aware of a 3 o'clock webinar that many of you are interested in on another Healthier Washington topic the Alliance is leading. But we are going to give you an update on waiver activities and the discussion with CMS, where it stands now. We're going to review goals for the Medicaid transformation, just as a quick contextual reminder. We're going to really focus today's discussion on the development of a transformation project list, and in particular, the template that just went out soliciting your ideas for those projects. And finally, our intent here is to leave plenty of time at the end of this for questions and answers, hopefully. There are 3 basic strategies to Healthier Washington. I'm sure many of you on this webinar may have even grown tired of hearing these, but I think it is important enough in the policy direction that informs our Medicaid activity to cover again briefly here. The first thing we are trying to do under Healthier Washington is build healthier communities through a collaborative regional approach. We want to ensure that healthcare delivery focuses on the whole person and their needs, and we want to improve and fundamentally transform how we pay for health services across the continuum of care. You will see, I think, and we'll continue to see in the Medicaid transformation process, how all 3 of these themes continue to be a driving force in the work. So quickly in the way of updates, first starting with CMS and our conversations with our federal agency partners there. Just as a brief reminder to folks who may not have been following us closely, our discussions with CMS through a technical assistance opportunity offered through the National Governors Association actually started last fall in November. So we've been having, at first, very informal, conceptual level discussions, and now very formal ones now that the waiver has been submitted for over a year now. And we have reached a new critical phase with the August submittal of the application, and those discussions, of course, are becoming much more focused as a result. So just going in the order they're listed on the slide there. First, we must say that the threshold issues that CMS and the state still must address are issues related to the financial elements of this waiver. As folks on this call understand, we are asking for a very significant federal investment over 5 years, and that investment is conditioned on something called budget neutrality, which means our federal partners must believe that they're not spending more over this 5-year duration than they otherwise would on the Medicaid program. We believe significant progress has been made in this area in CMS understanding the state's position, and we are also aware of significant effort within CMS to get back to us with substantive next steps and questions as to our budget neutrality approach, which is conceptually defined in the application, and more to come there. In addition, with CMS, with our partners there, programmatic discussions continue across all 3 initiatives. Today, I'll remind us we're focused really on Initiative 1 and how it, though, does tie to Initiative 2 and 3, but understand that those programmatic discussions with CMS include all 3 initiatives. And finally, in the way of update, understand even as recently as yesterday, Virginia just submitted a similar Medicaid waiver application to the one that we have submitted, and other states are seeking similar consideration. So understand that the discussions upcoming with CMS are not just in a Washington state bubble. They have great national implications for other states that are seeking similar arrangements with CMS. On workgroup activities, just briefly, we did provide updates on workgroups this week, and they are posted on our website in some detail. And you will note a bias that wherever possible, whenever possible, we are trying to use existing workgroups which is an acknowledgement that many of you on this call are engaged in many, many different activities and being pulled already a dozen different directions. We want this waiver to be complementary of those broader Healthier Washington related initiatives and discussions, and we believe we are achieving that through our approach to work groups. We would welcome, of course, any questions you might have or concerns with that approach as part of this webinar. And finally, I must say that the website has improved, believe it or not. There is a tremendous amount of Medicaid transformation resources for all three initiatives at the link that's posted there, with regularly posting updates, so keep a careful eye on that, as well as, of course, the email blasts that folks, in fact, may be quite tired of, but will continue to come your way for the duration of this effort. So Medicaid transformation is about achieving the AAA. Under the umbrella of the Healthier Washington effort, but we've set out specific goals for the Medicaid program under this waiver application, again, which by now may be familiar to you. First, we want to reduce avoidable use of intensive services and settings. This includes acute care settings like hospitals. This includes nursing facilities. This includes avoidable psychiatric stays at state hospitals and private hospitals. It includes traditional long-term care services. And we've also included a criminal justice element, recognizing that we can no longer afford for our criminal justice system, jails and otherwise, to be a default behavioral health delivery system. We must do much more on the front end of our Medicaid delivery system to address care needs as they present. So our goal is to reduce avoidable use across all of these varied settings, where sometimes intensive services are being provided that are very necessary but could have been avoided through better front-end intervention. The second piece that's very much tied to that, and none of these, of course, are mutually exclusive, is we want to improve population health, focusing on the prevention and management of key disease categories that you see listed there. Third, we want to leverage the waiver to accelerate the transition to value-based payment. This is not just a term of art or mere rhetoric for us. We do want to fundamentally transform both the way we contract with service delivery systems through managed care arrangements, but more importantly, how providers in the broader delivery system are experiencing those arrangements and being held accountable for improved service delivery. And finally, we want to ensure that Medicaid per capita cost growth going forward over the duration of this waiver is 2 percentage points below national trends. To achieve those four goals, and against the backdrop of Healthier Washington, we in our application have proposed 3 initiatives. Again, we are zooming into Initiative 1 today and the development of project ideas. But Initiative 1, to remind us, is transformation led by and through accountable communities of health. Each region through an ACH will be able to pursue transformation projects focused on health system capacity building, care delivery redesign, and population health improvement, which we'll talk about those domains in a bit further detail. Critical here, Initiative 1 in our approach, because it's very unique from other similar Medicaid waiver pursuits. Accountable communities of health, in fact, are very unique among other state approaches to this question, but the fact that we are engaging the necessary multiple sectors for sustainable health transformation is something that is a true demonstration that Washington State is providing for the national conversation. Initiative 2 is service options that enable individuals to stay at home or delay the need for more intensive care in the long-term care arena. We here are talking about a broadened array of long-term services and supports. And again, much further detail in the application and supporting documents on the website. And finally, Initiative 3, which is targeted foundational community supports, targeted supportive housing and supported employment services offered to a targeted group of Medicaid beneficiaries most likely to benefit from these services. And again, ongoing work group activities are in support of all 3 of these initiatives. So then we're moving to the critical arena of, and the focus of today's webinar, that is the development of transformation project ideas. One thing I'll say here just at the outset, in some ways project, the term of art, is a misnomer. We are talking about sustainable, impactful health transformation that lasts far beyond what a typical project duration might be, or what we might be used to thinking of in the way of projects. So understand that as context as we go through today's discussion, and in some ways focus on sustainability of these efforts. So why are we even asking the question, why the solicitation of ideas at this stage? Well, number one, they're critical, of course, for ongoing waiver negotiations with CMS. They want to understand the deeper dimensions of Initiative 1. They want to have a better sense of how Initiative 1 dollars would be invested. And part of the project idea phase is building out the broadest list possible of ideas in a very transparent way so that we can start informing CMS of our intent. We must be able to, as a state, demonstrate how we will transform the delivery system in a way that supports CMS's goals. You'll note these aren't much different than our own stated goals: providing better care for beneficiaries, addressing social determinants that affect people's health, paying for performance, and fostering innovations, again, important here, that are sustainable over time. We also need to formulate details around what we are doing, what CMS will be investing in, and why this is important for Medicaid. We also, at the outset of this process, even consistent with the concept paper's release in July, we're committed to a transparent process for building out the transformation project menu. This is a very, very critical component of that transparent process. Understand that we are not behind closed doors building out a secret project list. This is intended to be a public exercise and a very stakeholder-driven exercise, and we are very eager to see your ideas submitted by mid-January timeframe. Finally, this is an opportunity for you to propose project ideas that reflect the priorities of your communities respectively, as well as the state, and ultimately, most importantly, the people we are all responsible for serving in the Medicaid program. So there are a few must-haves with transformation project ideas that we hope inform this solicitation phase. First, maybe obvious statement, they must support the 4 Medicaid transformation goals. And again, there's state goals and CMS goals that are very, very complementary of each other, and we've provided a list of both for you in the template document. The other thing we've established from the very beginning of this effort is they need to have a foundation in evidence-based or promising practices research. That is to say, even where there is not a strong literature basis for an intervention, it must meet the state's definition of promising practice to be considered the level of investment that is being contemplated here. Third, promote integrity and objectives of the federal Medicaid program. Importantly, this remains a federal-state partnership, and in particular, the partnership is made even more significant with the infusion of federal resources we are considering. So ensuring program integrity and overall federal Medicaid objectives being met is, of course, important. Having the potential to show a return on investment within the 5-year waiver demonstration. Here I would make, I hope you hear it as a key statement. We are big believers in a balanced portfolio of project endeavors under the Medicaid transformation program. That stated, and as we even ponder short and long-term investments, we must be able to show from a sustainability standpoint that we are achieving across the project portfolio within each region a return on investment, again, within that brief 5-year time frame. This is critical and should inform the project idea phase, and we are open to your further questions on that if you have any. We need to ensure that the project ideas will positively impact a substantial number of Medicaid enrollees. Here's an idea. Think big, start focused, and scale fast. Projects do not have to be deployed on a region-wide basis from day one, but we think it's important that it be demonstrated that they are in fact scalable and replicable over the 5-year period. They can't stay small because that's not the notion of region and statewide Medicaid transformation that is being pursued here. Another thing worth noting, they need to be substantially different than existing efforts. So this is not about supplanting under Initiative 1. This is not about supplanting existing transformation efforts. They need to address significant health needs in a particular region or on a statewide basis. And they need to show evidence of collaboration in the project planning phase. We've asked specifically that you name both traditional and non-traditional providers that would assumedly be involved in the implementation of the project, and even that collaboration, to the extent you can show it and demonstrate it in this idea collection phase, that's also helpful to the process. So there are 3 domains. I know we're dealing in lots of lists and we're going fairly fast, but we do want to preserve some Q&A time, so I hope you'll forgive us. Domain 1 is health systems capacity building. These are strategies and projects that build provider capacity to effectively operate in a transformed system. As indicated in the template document, these supports may be needed to complement projects related to care delivery redesign and pop health domains, or to support delivery of benefits available through initiatives 2 and 3. I would say we have a special interest, in fact, in understanding, if applicable, how Domain 1 investments tie, meaningfully so, to initiatives 2 and 3, and we'll be interested in your ideas on that front. Domain 2, care delivery redesign. This is statewide scaling, spreading, and sustainability of care delivery models, projects that integrate systems of care and supports to address the health and recovery needs of the whole person, developing clinical community linkages, and building better transitions of care that really serve this whole person interest. That is a major, major theme of our Medicaid transformation effort. And finally, domain 3, population health improvement and prevention activities, targeted clinical and community prevention and health promotion. Must focus here, importantly, on Medicaid beneficiaries and be consistent with the waiver goals. That, of course, goes for all 3 domains. So these project ideas are really a starting point. You'll also see a starter list that's in the application and referenced in the template guide. Your comments, many of you during the public comment period have added a little to our process, but this is where we will be gaining the most substantive additions to our thinking so far on projects. We will still need the details for the ideas on the current list to continue forward, so importantly, as you contemplate sending us your ideas, don't assume that because they're referenced in the application or template document that we have full-fledged project ideas and proposals over here as of yet. Certainly there are areas of this that have had more thinking behind them, but don't, again, presume that in your idea submissions to us. So again, delving a bit deeper into this with domain 1. Think here around workforce development, system infrastructure, supports to providers. Domain 2, think specifically about bidirectional integrated delivery systems. I believe we've been clear in prior conversations and should reinforce here. Integration of delivery systems and financing is a statewide mandate, and so we envision this being a statewide project, details of which are still very important, details of which we still want your contributions toward. Access to care coordination, case management, and transitional care is something we have heard a great deal about in your comments. And finally, outreach, engagement, and recovery supports that are, of course, critical components to any care delivery redesign effort. And finally, with domain 3, think specifically here around behavioral health issues, mental health, and substance abuse, chronic disease prevention, getting as upstream as possible with some critical disease categories that greatly inflict the Medicaid population. And of course, promoting healthy women, infants, and children, especially given that we cover now well more than 50% of the children in this state. This will continue to be a key focus area in the project dissemination phase. So then, this is the timeline. Believe it or not, this graphic has remained relatively consistent, even as that little gold star there has moved along, which we're good. It's always good to observe progress. That star is in fact moving. You see a red circle around what we're talking about today, and that is the identification of transformation projects. I think this puts this in helpful context, understanding that this already has been a significant process, and there is significant process ahead of us, even as we aspire to a spring approval date for this waiver. So we have come a long way, but really the heavy lift is just starting, and we appreciate you joining us in this effort. So here is a bit more detail on that red circled item on the previous slide, and that is a timeline and process for the project idea phase. Understand all of this, of course, is subject to change as we get more information from CMS in the negotiation phase. This is what we are thinking as of today. First, we are immediately now with you all in the identification stage. All project ideas, this is our request, need to be submitted using the transformation project template. We have already had some questions raised around our 3-page limit, and understanding that the template itself is already a page and a half. We are going to be somewhat flexible. The hope here is, though, that folks are as concise as they possibly can be in describing the elements of project ideas at this stage. But of course, we will be flexible. Nobody's ideas are going to be turned away at this stage. We will then, starting in mid-January, be evaluating project idea submissions. We intend to collaborate with some consultant expertise to develop the criteria for this evaluation stage. Projects that meet the criteria through a winnowing phase will be added to a draft project list. This will be a transparent process. You will know what's on the draft project list for purposes of CMS negotiations. The next part of the phase that we're envisioning, but is probably the least clear now because we're not certain how much CMS will demand in this area, is we expect some elements of this project list to be a negotiation point with CMS. It is a key part of negotiations because this is where a key component of the investment is being made. Naturally, CMS will want to understand how these projects align with their goals and the state's goals, and how they align with the financial elements underlying this waiver. And finally, we are envisioning in the springtime, at the beginning of the ramp-up phase that we've envisioned upon waiver approval, that we would be finalizing that project list to be published at that stage for public comment, which is consistent with how CMS has approached similar processes in other states. A final project list we anticipate would be included in special terms and conditions, again, at the discretion of CMS, excuse me, and guidance about project applications through the ACHs will not be developed, of course, until the waiver is approved. Although at any point in this process, we are very much open to your ideas about how that should be structured. So getting into the logistics for just a moment. We did provide a deadline of January 15th. I think you'll understand now from the timeline discussion, you'll appreciate the context for that deadline. We recognize we are asking for a lot over a 6-week period of time, and so greatly appreciate those that are already putting forward great ideas in this process. Really, the suggestions need to be submitted using the template for transformation project suggestions, now available on the website and having already been distributed through the feedback network. The email address is provided up there. The Medicaid transformation inbox is where we want those completed templates to be emailed. To the extent practical and possible, please consider being concise with no more than 3 pages, if at all possible, again, respecting the fact that you have a 1.5 pages of template to deal with already. And submissions will be posted on the Medicaid transformation website for public review and comment. This is key. Not every state that's endeavored on a similar process has done it in this exact fashion. But again, bearing in mind our commitment to a transparent and open process at the front end of this, as the ideas come in, they will be posted for public review on the website. So we are not intending to wait until January 15th to post those for folks' review. So then the template. And again, being cognizant of our time, we're not intending to read every word on these pages, but we want to call some things to your attention. The template has 4 key sections on it. The rationale for the project, a project description, core investment components, and project metrics. It reflects critical information that CMS will ultimately need and the state will need to support the potential investment in a given project. It is not the be-all, end-all, and to be very crystal clear about something, this project template for idea submission is not a project application. That will come much later in the process as the timeline indicates. This is simply a way of gathering ideas at this stage. So let's walk through this a bit. First, on the rationale for this project. Tell us why the project is needed. Make as convincing of a case as you possibly can around the problem statement that you're addressing. We are asking, of course, CMS for upfront federal investment in our efforts to support and sustain delivery system transformation. They ultimately want to know what projects we would invest in and why. They want to make sure that those align with and will actually drive the change we have proposed in the application. It must also be very crystal clear to the state and to CMS that the projects will benefit Medicaid beneficiaries, as this is a key question for CMS. I would add here as well, because this is a question often raised, investments also must be going to the providers that are serving Medicaid beneficiaries. Project ideas that come forward in service of broader delivery system interests or of providers that are not in the Medicaid business today will not be well received by CMS for certain when it comes to the federal investments they're contemplating. Also important here is supporting research. If you'd indicate any known relationships with the state and health or healthcare improvement priorities at the local regional level. The types of supporting research here can include peer-reviewed journals, research from SAMHSA, CMS, CHCS, WISP, and others. Also important here, if you can, make clear the relationship to those federal objectives that we discussed earlier. CMS will want to see how the underlying projects we're proposing support their federal objectives. We hope at this stage the project description is pretty self-explanatory, but we here in this phase of the template want you to describe what the project is and identify the target population. Check all applicable boxes in this case. They are not mutually exclusive. And projects must be connected to one or more of the goals for Medicaid transformation as outlined in the waiver application, bonus points for being able to connect them to all of the goals in the application, and I am saying that in jest a little bit. We are not looking for an express commitment here from potential partners, but strong project ideas will reflect community linkages and cross-sector collaboration. Some of these discussions have already transpired at a local level, for instance, at Accountable Community of Health tables, and to the extent you want to reflect those conversations in your idea submission, that is also helpful to us to understand the context and community discussion behind it. So then the core investment component is the next layer of the template document. We do not want any of this to be an overly time-consuming task, but we do need to have a basic understanding of the potential financial support necessary to implement the project as it's envisioned. We need to emphasize here that this is order of magnitude or ballpark. We are not asking for a commitment. We are not asking for a full-fledged budget proposal. That will be necessary. That will come later. So any initial work that has already been done on that will be of great value going forward. We need this now because it provides an overarching and basic framework to begin the modeling of various investment needs across the domains of investment. And here, project metrics. I can't stress this, this section probably enough. It's particularly true in the New York experience, and I would also say in the Oregon experience, that metrics around their Medicaid transformation proposal drove the programmatic discussion with CMS. They want to know what accountability is being exercised at the state level. They want to understand how that accountability goes from the state to any delivery system partners, managed care plans, providers, or others. They'll want to understand the accountability at the local community level, at the ACH table, for the collective work that's necessary to pull it off. Specifically, and I think a strength of Washington State's Medicaid transformation proposal is we have done pretty phenomenal work at the statewide level on the development of common measures, both in support of directly Medicaid program interests, work that transpired in 2014, actually in 2013, excuse me, and the work to develop an initial starter set of common measures across payers, which concluded in 2014, at least the starter set was concluded. We provided links to those measure sets for anyone who's not as familiar with them. Importantly, to the extent possible and practicable, please tie the ideas to those metrics that you think are most movable by virtue of the intervention being proposed. That will greatly aid us in the discussion internally, of course, but most importantly with CMS, for whom the issue of project metrics is extremely important. Ultimately, improved patient outcomes is the most critical element for CMS, so drawing that linkage is very critical. We will not simply here be tracking the status quo that we're already achieving. These should be and must be stretch measures. We have to show why $3 billion of investment in Medicaid transformation is appropriate. CMS will want to know where we expect to specifically see improvement, regionally, population-wise, or disease category-wise, for instance. This is what will ultimately support their interest in making a major investment, a shared investment in our state's Medicaid transformation effort. So believe it or not, we are getting into wrap-up mode here for at least the formal part of this presentation. We want to leave you with some key takeaways that we hope have been clearly expressed, but if you take away nothing, hopefully you can take away this slide. First, this waiver is a truly strategic opportunity for Washington State. We are proposing here to do something that no state in this country has done or achieved so far. There is a newness to this, and importantly, a demonstration component to this. We think we have a story to tell and something to prove, and something that will be very valuable to other states as they ponder their own Medicaid transformation efforts going forward. Second, we must be clear with CMS what we are doing, what they are investing in, and why it is important to the Medicaid program, and most importantly, to the members we serve on that Medicaid program. Third, we need you. Your input and involvement will ensure that priorities and needs of communities are understood by both the state, our collective agencies that are working on this waiver, and our federal agency partners. Timeline pressures are critical here. You saw that reflected in the earlier timeline slides. We feel it imperative that by the time spring rolls around, we have as close as possible at least conceptual agreement to this waiver approach. Short of that, we're very concerned that given the short timeline we have with the present federal administration, that elements of this demonstration may not move forward otherwise. So we are under key timeline pressure here, and that is one of the absolute key drivers and what's pushing us on the timeline path we are on now. As I stated earlier, we need project ideas at this stage, and that's one of the reasons we tried to be forceful about limiting the content and page level and volume that we'll be receiving back. Ultimately, we will need, before any projects move forward, full-fledged applications and proposals. This is not the stage right now for those applications and proposals. That will be in a later stage, and we are very much looking forward to getting to that stage in this process. And finally, we will continue to keep you informed of progress, both in the CMS discussions and further design of programmatic features that many of you are already involved in. And the best way to follow that progress is through our Medicaid transformation website, which you see posted here on this slide. We, again, have recently updated that with, I think, you'll find to be a lot of valuable information, and we hope you find it as a resource to you. Of course, as always, using the email address that was provided earlier in this slide deck, if you have questions or needs that are not otherwise being met, through this discussion, through the questions that follow, or through the website, please let us know so we can be responsive to that. I'll just conclude by saying thank you so much. We have fabulous attendance on this webinar, and it's a very good sign of the level of interest at this stage in the process. We very much appreciate your attention and now very much look forward to your questions and whatever answers we may be able to provide at this stage. And we'll go ahead and see those right now.
Well, thank you, Nathan. This is Jenny Hamilton from the Healthcare Authority. I've been attempting to bucket a lot of your questions as they're coming in, and we did receive a few questions prior to the webinar. So let's just start, Nathan, with the easy ones, the ones that are specifically about CMS. So the first question is the overall CMS focus just Medicaid?
Sure. Well, let me respond to that very directly. First, I think CMS understands that Medicaid fits in within a broader delivery system. You know, the providers serving Medicaid beneficiaries are serving Medicare beneficiaries, they're serving commercial payer populations, and oftentimes they're serving the uninsured as well. So CMS certainly understands that Medicaid is not a program unto itself. At the same time, and what's very, very critical in this waiver process, CMS's direct bottom line interest programmatically and investment-wise is in the Medicaid program and the interventions that directly serve the Medicaid population. So naturally, that is where the Medicaid waiver is focused. And a great question, opportunity to clarify. And it's important to note that it's not just, you know, when we're talking about the Medicaid program, we're not just talking about new adults. We're not just talking about the elderly and disabled population per se. We're also talking about dual eligibles that by definition are served in the Medicare and Medicaid programs today. And they too will be impacted through this Medicaid transformation proposal if we're successful.
And just to add on to that, we had a question about whether the waiver covers children in foster care, and we can say the answer to that based on what you just said is yes.
Yes, to repeat the question is, will the waiver cover children and foster care children covered under the Medicaid program? Emphatically, yes. And still, as of today, children represent almost half of the Medicaid population, and naturally, that's where many of the projects will be. I wouldn't say focused. We're total population focused here, but when you think of integration, when you think of care delivery redesign and population health strategies, we're talking about being focused on whole Medicaid population.
So let's just move into some more of the process around the submission of projects. Will the list of projects that make it through the evaluation be available for public review and comment?
Yes. Okay, so the question is, will the list of projects, once they're winnowed down through this process that was described earlier, will they be available for public comment? The answer to that is yes. We are planning for that next springtime sometime, conditioned on the CMS process negotiations and what they may require of the process. but we are absolutely planning to do that.
And just a follow-up question prior to that, how does HCA intend to post the project ideas as they're being received and any comments that come in on them?
Great. The question is, how will HCA be posting the project ideas as they are submitted? We will be using the Medicaid Transformation website to post the projects. Being very honest with you all, we have not contemplated yet the posting of any comments we receive on those projects, but we will get back to folks on that.
Oh, yeah, we told them we would.
Well, we have contemplated it, and we will be posting them. My apologies.
But the how is just to have them out there to encourage the mutual understanding.
Yep.
Sorry.
Thank you for the correction. You shouldn't have assumed.
I shouldn't have, did I? Okay, so I know you can get this one right. Okay. Who can submit the project?
Sure. Well, this is an open process. So while we are encouraging community-level, statewide collaboration, and we really want some of the initial vetting to be done at the community level for this, anybody can submit a project. There is no dedicated or designated entity for submitting project ideas at this stage. But we do, very importantly, so I want to make sure this is clear. We do encourage folks to vet project ideas with a broader cast and crew than they may otherwise have done in previous efforts of this nature.
So another really good one here, because I don't think we addressed this well in the guidance. If there is one project that people are interested in across multiple regions, would you rather see each region submit the idea, or would you rather have one idea that shows that multiple regions support it?
You know, it's probably not my place to be the de facto decision maker on this, but I would say from a team perspective and in a vetting of ideas perspective, just process-wise, if there is a significant consensus between regions around particular projects, we'd love to see that submitted as one project, if nothing more for practical reasons than the others. But if at the same time there are regional distinctions, indicate those in terms of, we would understand, for instance, integrated care model strategies may look very different in a rural part of our state from what an urban or suburban setting might call for.
And I would say that one of the points that's been made to us is that regions will learn from each other. So good ideas are good ideas, and regions may not have them in their repertoire just yet, but seeing them posted out there by other regions will give them the idea. So, and it will give the state a better idea of where everybody is really seeing priorities. So while not specifically called out within the core investment component, we believe it is imperative that projects outline the capacities needed to administer and manage the respective projects. So are we saying that projects could include both care delivery redesign components as well as health systems capacity building elements?
We are saying that. In fact, we encourage that if there are interventions or project ideas that are overlapping the domains, just be as clear as possible about what elements of those are overlapping. That helps, again, in our vetting process and with CMS. But we fully expect that many of these ideas will run the full gamut of the investment domains as well as the goals.
So what's meant by regional versus statewide projects?
Absolutely, we can address that. The question is, what is meant by regional versus statewide projects? This is a key question, actually. What we mean by that, first and foremost, is the implementation of Initiative 1 will be done regionally. This is an imperative element of the application. It focuses on the accountable community development playing a prominent coordinating entity role in that activity, and ensures twofold things. First, it ensures that the needs of a community are being met by a particular project undertaking, and it also ensures that accountability around that project undertaking and the measurable results is as close to the action as possible. So this is a critical element. Specifically, we envision there may be some projects that are implemented on a statewide basis because they have statewide value and are impacted by statewide policy direction that already exists. The best example that we've provided in previous discussions on this topic is integrated care models. We have a statewide mandate around physical and behavioral health integration for the Medicaid program, and project ideas. We are still soliciting project ideas on how we are to achieve that feat, but just be expecting that that will be a statewide undertaking. Importantly, however, for statewide projects and regional projects, the Accountable Community of Health, as we envision it, will be the coordinating entity. Again, this ensures fidelity to the care models being pursued, ensures that it meets community needs, and ensures that the right types of both traditional and non-traditional providers are included in the project's implementation. So I hope that is clear for the questioner, and if it's not, I hope they'll follow up with us.
We've received that question actually in a variety of ways from a variety of people. So a follow-up to that is that if a project has been signed off on by the ACH, meaning that the ACH, or presuming that the ACH has actually submitted the idea, would that be more likely to be successful in making it through the evaluation versus any other project?
I would say we're going to be judging all project ideas on a level playing field. And that level playing field is reflected in the template across the 4 different categories. And again, we'll be releasing very transparent criteria around how those are evaluated. One of the key metrics, though, in that evaluation will certainly be the level to which other entities that are critical to the success of the project have been engaged in any early conversations. Naturally, Accountable Community Health has a great environment in which to do that, but there are certainly other statewide and regional environments in which that activity can be undertaken. But that is one of the criteria in the template, is that we understand and see how other providers, how other groups have been engaged in the formation of the project idea. So we encourage, whether it's being done in the context of an ACH or in a different context, that you provide that information to us in the project idea submission.
Following up on criteria like that, can we be more specific at this stage about what impacting a substantial number of Medicaid beneficiaries actually means?
More than 5? No, I'm kidding. Well, I would welcome ideas, frankly, from folks on what is substantial or not. We did wrestle with the idea of providing a number that's substantial, but it would have been as arbitrary as any. What we have to show evidence of under this waiver and under its implementation is that we are impacting a broad swath of the Medicaid population with these interventions. We understand, though, that not every project is going to target all 1.8 million beneficiaries of the program as it stands today. So just describe to us what the target population is and whether, from your vantage point, it meets that substantial criteria. We're not drawing any artificial thresholds at this stage in the game, but we expect questions from CMS as to the scale of these projects and how many people, how many Medicaid beneficiaries they're impacting. That's why we've asked the question the way we have.
And I would have to say, from a staffing point of view, that looking at individual elements of criteria is not really going to help you. To say that we impacted all Medicaid beneficiaries, but all we did was a teensy-weensy little thing, that's not going to carry the weight of CMS as impacting a targeted set of people and having a substantial impact that has a substantial effect on the Medicaid transformation goals. So if you think about effects on the Medicaid transformation goals primarily, that's better than looking at what the individual word substantial might actually independently mean.
We apologize for using undefined terms. There's plenty of them in this process.
Oh, here's a good question. Follow-up to that, really. Does a project need to address or impact solely or exclusively the Medicaid population?
The question is, does the project idea need to impact exclusively the Medicaid population? By definition, if it's being funded with Medicaid waiver dollars, those dollars have to be directly tied to the Medicaid population. But I'll emphasize a point I made earlier, which is CMS recognizes, as do we, that the Medicaid delivery system is not a fiefdom unto itself. It is not a distinct and separately definable delivery system. It is an amalgamation of providers and health systems and other service providers that are serving the full marketplace of beneficiaries, be they Medicare, commercial market, uninsured, or otherwise. And so be as targeted as you possibly can be with regard to how Medicaid investments would be used for a Medicaid population, but we recognize that some of the additional health system ramifications of this Medicaid transformation will be felt across the board. And that's okay. That's actually a good problem to have, and I think CMS is willing to have that problem as well.
And maybe that in some respects answers this next question. We have a couple of questions actually trying to quantify how many projects we expect and whether we have any idea of how many projects will be required under each domain.
Sure. The question is how many projects ultimately will be on the menu, or how many projects under each domain. The simple answer to that is we don't know yet, but we do know some things it won't be. It's not going to be 100, it's not going to be hundreds or thousands of different projects, all with their own tight and neat definitions. That is not the scale and type of transformation that we're talking about here, and CMS has been very precise and very clear with us that that is not a demonstration proposal that they're willing to even consider at this stage in the game. So we do envision a narrowly defined menu that ultimately comes out of this. I don't think we are willing as of yet to commit to a number. Part of this idea stage is figuring out what type of number might be appropriate here. And we know that there's a full range of opinions on this, and we would like your further opinions on this, frankly, around the level of desired flexibility and options, and the need to streamline and narrow that list of options to ensure ultimate scalability and to ensure that systems of care that overlap regions oftentimes aren't being asked to do 10 different one-offs within each region. So we recognize this as a tension under Initiative 1 and would invite your further thoughts, both as part of the idea submission phase, but as well in the broader discussion.
And to add to that point, as you're thinking about the term project, it really is a term of art. And we're looking for you to think innovatively about the construction of a project. And so right now you're looking at a sample list of a variety of ideas. You may see that 3 or 4 of those ideas really come together, and that would be the kind of project that would be ideally representing Medicaid beneficiaries in your region. So we're not looking for the independent one-off. In fact, we're looking for the efforts that maybe tie a variety of these things together. Oh, here's a good one. Maybe that's a carryover from that. For a statewide project, for example, would it be acceptable to lay out a plan for coordinating with the ACHs rather than having confirmed the details of coordinating mechanisms with all the ACHs prior to the January submission?
Yeah, that's a great question, and I'll repeat it just so everyone heard it. The question is for a project that has more statewide appeal. And again, I would encourage folks not to think of this phase as being either statewide or regional. In fact, your ideas that have both contemplated will, I think, be even more powerful. But that said, the question is, if it's a statewide project proposal, what kind of evidence do we have to show, in this case of coordination or collaboration with ACHs, prior to the mid-January date? Or I might extend that question out to any collaboration. What kind of details around the implementation of that project need to be provided as to how it would be handled? Importantly, and I want to stress it, we are looking for a conceptual level discussion of that, both what has already occurred in the way of discussion and what needs to occur in the future. We are not asking in the idea submission phase that you have all of those details wrestled to the ground. And in fact, I would encourage us not to try to wrestle all those details to the ground at this stage, given how much uncertainty awaits us in the project idea winnowing phase, and as well as CMS negotiation that is underlying all of this. That said, whatever, not to talk out of both sides of our mouth here, but whatever current thinking or existing thinking may be around some of these collaboration opportunities, please share that with us. I think there's a great opportunity for cross-sector and cross-agency learning on that front.
So we have a number of questions coming in, all worded a little differently, but I'll read one specifically because it gets to some apparent confusion on the actual timeline of the gathering of the actual ideas. what happens with CMS, and how this all then generates down to eventual funding. So let's just start with this one, and maybe we could flip to slide number 14, which actually shows the timeline. So the first question is that one. If a project is not submitted by January the 15th, 2016, is the idea out of the running, or is it moved down the priority list when finally the actual list and the application guidance comes out?
Let me first address that. This is not about excluding ideas, this process. But I'll be honest that given and I guess I should repeat the question in case folks didn't hear it. The question is, if a project idea is not submitted by mid-January, is it out of the running for any future consideration? The easy and short answer to that is no, with a major caveat. There is going to be a lot of thinking and a lot of process and a lot of effort spent on the ideas that are submitted through this process. I think an idea that would be outside of that process would have to hit an incredibly high threshold for consideration, given how tight this window is and how much conversation will be occurring concurrently with CMS and in the negotiation phase. So I would really, really urge people not to sit back and wait to see how this process unfolds. And even if the idea is very high level and very conceptual and very not much built out, please still submit the idea. That will, I think, strengthen this process and ensure its comprehensiveness and that we're not missing out on anything. So we, at this phase, would not suggest that there's any absolute exclusionary criteria, but safe to say that for assured consideration, the idea needs to be submitted by mid-January.
So maybe, Nathan, you could take a few minutes to repeat what happens after that and how we're getting from the list that comes in to conversations with CMS.
Sure. The question is, and given the types of questions that we're receiving, we felt it's important to pull up slide 14 here around timeline and process to talk about the phased elements and the iterations of this. Again, to be clear, we are presently in the idea collection phase, the first yellow highlighted box. There will be an evaluation phase to follow where we look at those ideas and assess them into some prioritization list. There will be, in the February to April timeframe, we envision, we are not certain, conversations with CMS around that project list that has been winnowed. And there will be a finalization process later in the spring around a final project list that will be vetted with public comment. And that has been a requirement of previous CMS demonstrations, and that is something we are committed to doing. I hope that's helpful for folks, and we are certainly willing to follow up to the extent anything is not clear about this particular timeline.
And I would like to point out there the intent of having a waiver approved end of April, but it will take a considerable amount of time after that to go through the details of an application process and to actually get to where funding and selection of projects actually occurs. So this question actually represents a number of questions. The deadline for ideas appears to be ahead of the formation of an ACH that would have extensive county involvement. As we ramp up our ACH, how should we address project selection when we don't have our community partnership up to full speed?
The question is how to approach community partnership as accountable communities of health in particular are still norming and forming. I'll point out that the first 4 such ACHs have been designated as of just 2 weeks ago, and we expect the rest of accountable communities of health to be designated as soon as January for a total of 9 ACHs by that time. Now, to be 100% clear about this, designation of ACHs does not constitute certification or any preconceived idea that they're ready to serve in the coordinating entity role that's envisioned under this waiver. That certification and those credentials, which will be a part of our final terms and conditions, will be a separate process, and not a process we're going into too much depth today, but certainly will be a process further discussed in materials posted on the web, but as well perhaps for a future webinar. So I don't know how much further detail to dip into, but we do absolutely recognize that we are standing up a Medicaid transformation waiver effort while community-level efforts, particularly around accountable communities of health, are still coming together as well. And actually, we view that as a strength of this project. Many other states have gone down the Medicaid transformation path without any community infrastructure at the outset. We have spent 3 years already building and planning for that infrastructure, which puts us in a much stronger position, arguably, from what other states have gone into similar discussions with. More to come on that from a timeline perspective, but we really are focused in today's discussion on what's going to get us to a waiver application approval. There's much more timeline than that, given that we conceive of a 2017 start date for Initiative 1, at least as it's expressed in the application.
Which means that actual project selection by accountable communities of health would not be something that would occur until much later next year. So, back to a simple question. Is there a limit to the number of projects an ACH can submit?
And again, the question is there a limit to the amount of projects an ACH or any other entity can submit? To be clear again, project ideas, there is no limit. What we want to ensure, though, is, or to the degree possible, if there are similar ideas, let's have those discussions before those ideas are submitted and not leave it to folks on this end and interpretation within the criteria and other public comments to try to do that homework for us. So we encourage as many ideas as you can come up with that you believe meet the Medicaid transformation goals and the other specs that are indicated in that template. We have not prescribed a limit on number of ideas that we proposed.
We have a number of clarifying questions around our terminology that projects are to be substantially different than existing efforts. And there's a question about, isn't scaling out existing permanent supportive housing to include Medicaid clients, wouldn't that fit under being substantially different? Let me see if that's a similar thing. So what do we mean by substantially different?
There we go, substantially different. What we're really getting at there and what we think is important for the CMS audience is that the effort that is being funded with Medicaid dollars is not being used to supplant directly and otherwise separately funded either through federal funds or otherwise effort. It is, in fact, exactly what the questioner mentioned. It is about scaling and replicating proven evidence-based interventions that have been limited in their scalability because of lack of investment or other business limitations on their scale. So we are, in fact, exactly talking about bringing to scale those interventions in our communities and at our state level that we know work and work well in achieving the objectives set forth. But importantly, we need to make sure that as we describe it to CMS, that it's clear that this new investment is being driven at new scale, new replicability, new expansion of those proven interventions. And that will be something important for us to wrestle with. And I know we're running short on time.
I think we have time for one more question.
One more question.
For projects that are not submitted through an accountable community of health, but submitted by an independent organization, for example, will the accountable community of health still play the coordinating entity role?
Yes, and remember, these are project ideas, so these are not project submittals. The questioner asks, will projects not submitted by an ACH still be coordinated in the implementation phase by an ACH? The answer to that is yes. In the waiver application, it talks in more detail about that coordination role and what it entails. But at this phase, we are collecting ideas. Implementation discussions are something that await us for later in 2016, as we've discussed. But to be very precise about this, the person submitting the idea has no bearing on how that idea will be implemented under this waiver. But we'd really like to thank folks for the time we had. Again, an incredible participation rate. We hope this has been clarifying. We hope it has been helpful. We hope it is prompting further discussion. And we will be mindful about following up with any questions that we were not able to get to on today's webinar and continue the discussion with many of you as we have already been doing so over the last several weeks and months. So thanks again for your participation, for your fabulous questions that were right on point, and we'll look forward to carrying on this conversation.